I'm Kaitlin, and we'll get this presentation started today. So we're going to be talking about ARDS with a twist of COVID-19. So the learning objectives for today include review the background of acute respiratory distress syndrome, identify treatment recommendations for ARDS, and discuss the treatment recommendations in patients with COVID-19 ARDS. So, acute respiratory distress syndrome, also known as ARDS, which I will use for the remainder of the presentation, is an acute diffuse inflammatory form of a lung injury that is associated with a variety of etiologies. True ARDS involves diffuse alveolar damage throughout the lungs characterized by hyaline membrane formation and thickening of the alveolar walls. These patients typically present with severe hypoxemia, which doesn't disappear following recruitment, impaired lung compliance, and increased dead space. Approximately 10% of ICU patients develop ARDS, and severe ARDS has a documented 50% mortality rate. So ARDS was first described by Ashbar and colleagues in 1967 in a 12-patient case series. This consisted of rapid development of respiratory distress and was the onset of tachypnea, hypoxia, and loss of lung compliance. They were also the first to describe PEEP, which was not typically used at that time. Later in 1994, the Consensus Guidelines of American European Consensus Conference was the first to describe ARDS. And they described it as severe hypoxemia, including a P to F ratio of less than 200, bilateral infiltrates on chest x-ray with no evidence of cardiogenic pulmonary edema. And these previous definitions, of course, resulted in some criticisms, such as high rate of intra-observer error when reading a chest x-ray, hypoxemia criteria can be altered by the ventilator settings, and of course, low specificity for ARDS itself. So the Berlin criteria was then later developed and is now used to diagnose and classify ARDS. It breaks down into 4 categories: timing, chest imaging, origin of edema, and oxygenation. Timing must be within 1 week of clinical insult with new or worsening respiratory symptoms, and your chest imaging must have bilateral opacities on chest x-ray that aren't fully explained by effusions or lobar or lung collapse. Lastly, origin of edema is usually respiratory failure, not fully explained by cardiac failure or fluid overload. And then oxygenation is broken up into 3 categories. So you have your mild, which is a P to F ratio with greater than 200 but less than 300, moderate, which is greater than 100 but less than 200, and severe, which is a P to F ratio of less than 100, all while having a PEEP greater than 5. So even though this criteria existed, there is still criticisms with the Berlin criteria as well, such as other parts of the world do not have access to ventilators, so how do we classify those patients in ARDS, as well as emphasis on no cardiac source. Many of our patients that also have heart failure can also present with ARDS, so how do you diagnose them? As well as the hallmark pathophysiology of ARDS is diffuse alveolar damage. When looking at 72 patients that came in with the classification of ARDS based on the Berlin criteria, only 45% actually had diffuse alveolar damage. So a little background on the pathophysiology. ARDS is thought to be caused by such as sepsis, pneumonia, an aspiration event, and it all leads to your diffuse alveolar damage. So the acute phase, also known as the exudative phase, this occurs anywhere within the first 7 days. What this phase is characterized by diffuse alveolar injury and capillary endothelial injury, and neutrophils adhere to the pulmonary capillaries and they bore through the little holes through the basement membrane. These holes then allow the large plasma proteins to move through, and this disrupts the Starling equilibrium curve. This causing diffuse pulmonary edema, which leads to your reduced gas exchange. So the neutrophils and T cells then mitigate into the inflamed lung, amplifying the damage. Late phase ARDS is then further broken down into your exudative phase, or your proliferative phase, which is typically 7 to 21 days, and your fibrotic phase. So your proliferative phase is usually used for recovery during this time, and is where you try to reabsorb all your fluid. And then your fibrotic phase is the extensive pulmonary fibrosis, loss of normal architecture, and emphysematous lungs, and this is usually typically due to prolonged mechanical ventilation. So some common risk factors include pneumonia, non-pulmonary sepsis, aspiration, trauma, age, non-white race, and genetic. And it is important to realize that although age is a risk factor, it does not necessarily mean increased mortality for these patients. So COVID-19 seems to be the big talk everybody's talking about these days, and the coronavirus is an enveloped positive single-strand RNA virus that can affect a wide variety of host species. It's divided into 4 genera, your alpha, beta, gamma, and delta, with alpha and beta being the ones that typically affect mammals. However, we are now seeing the delta strain. So after infection, your type 2 cells release inflammatory signals, and this recruits the macrophages. The macrophage then release the cytokines, and that causes vasodilation, causing more immune cells to come into the site of injury and exit the capillary. Fluid then accumulates in your alveolus, and the fluid then dilutes the surfactant, which triggers the onset of alveolar damage. Once this collapses and leads to decreased gas exchange and increased work of breathing, the neutrophils are then recruited to the site of infection and release the reactive oxygen species, causing your ARDS. So this then can destroy and go further into the bloodstream, causing your SIRS-like response, and ultimately could go to multi-organ failure. So COVID-19 patients can be classified into asymptomatic, mild, moderate, severe, or critical. And for the purpose of this presentation, we will focus on the critical population, which consists of your ARDS and your septic shock. So ARDS continues to be a topic of interest given the uncertainty of the disease state. When it comes to treatment goals for ARDS, the first is to treat your underlying cause, such as your pneumonia, your aspiration event, your blood transfusion reaction, or COVID-19. Second is providing supportive care, all while not trying to harm the patient with doing the first 2. So when thinking about this, it can be broken down into your ventilator strategies versus your non-ventilator strategies. And for the purpose of this presentation, we'll focus on the ones that are circled today. So we'll go through tidal volume, plateau pressure, positive, your PEEP, as well as neuromuscular blockade and vasodilators, prone positioning, and steroids. So the Society of Critical Care Medicine in 2021 posted COVID-19 guidelines, and these images recommend therapeutic management for patients with COVID-19 as well as COVID-19 and ARDS. And throughout the presentation, we'll discuss the ones with the stars in further detail. All right, so we're going to get a little interactive with our presentation. We'll have 3 questions throughout. So our first self-assessment question, I'll read the question and then the answers, and then if you guys can raise your hand to pick your answer, that'd be great. So patient JR is admitted to your medical ICU, intubated for septic shock secondary to pneumonia. His past medical history consists of type 2 diabetes, and he's on his home metformin. He presents within 5 days of new shortness of breath, and he has bilateral opacities on his most recent chest x-ray. His most recent blood gas shows a P to F ratio of less than 100 with a PEEP greater than 5. Which classification of ARDS according to the Berlin criteria, does this patient fall into? So A, moderate ARDS, B, severe, C, mild, or D, does not fit the qualification of ARDS. So anybody for A, B, C, D? All right. Thank you for participating. So the correct answer is B, and that's because he did present within the 7 days. He has the positive bilateral infiltrates on x-ray. His P to F is less than 100, and although I did not go over the cardiogenic component, he had no history of it, and so we just assumed he did not have that part. All right, so first we'll get into the ventilator strategies, and I will preface with obviously I'm no expert in this given that I am a pharmacist, but we will go through some of the trials that discuss why we do the ventilator settings that we do. All right, so when thinking about ARDS, the functional lung size is decreased since many lung units are poorly and non-aerated due to collapse, flooding, or consolidation. And this places the patient at increased risk of ventilator-induced lung injury due to both over-distension of aerated lung units and cyclic opening and closing of the small airways and alveoli. So a subset analysis of data from the LungSafe trial actually looked at patients with severe ARDS, which they classified as a P to F ratio of less than 150, and that was an independent predictor of mortality if patients were using non-invasive mechanical ventilation. So it is recommended that clinicians should be worried about patients with this degree of hypoxemia and recommended to use invasive mechanical ventilation over non-invasive in this subset of hypoxemia. It is also, as we'll discuss further, it's recommended to use a low tidal volume, also known as lung protective ventilation, and this is anywhere from 4 to 8 ml per kg of predicted body weight with a goal plateau pressure of less than 30. And then it is important to optimize PEEP to maximize and maintain alveolar recruitment. All right, so with tidal volume. Tidal volume is the volume of air inhaled or passively exhaled in a normal respiratory cycle. So the goal is to maintain adequate oxygenation and carbon dioxide levels. And as seen on the slide, there are a bunch of initial tidal volumes depending on the disease state. So ARDS falls into your restrictive lung disease state with the goal 4 to 8 mL per kg, and this is to decrease peak alveolar pressure. So traditional approaches to mechanical ventilation use tidal volumes anywhere from 10 to 15 ml per kg. However, multiple animal studies and observational studies showed that this had consequential elevated peak plateau pressures, and they were associated with significant barotrauma. So then in 2000, the ARDS trial looked at using lower tidal volume with mechanical ventilation would improve clinical outcomes. This was a multi-center parallel group randomized controlled trial that included 861 patients. 429 of those patients were allocated to the traditional tidal volume arm, which consisted of 12 mL per kg of predicted body weight, and 432 patients were randomized to the low tidal volume group, which consisted of 6 mL per kg of predicted body weight, with a goal plateau pressure of 45 to 65 in the high group and 25 to 30 in the low group. Your typical patient was intubated on a mechanical ventilation with acute decrease in their P to F ratio of less than 300, with their bilateral pulmonary infiltrates on chest x-ray that had presence of edema, however, there was no cardiogenic component. The primary endpoint did look at 100-day mortality, ventilator-free days, and breathing without assistance by day 28. So this trial was stopped prematurely when the low tidal volume arm demonstrated a decrease in mortality, so 31% versus 40%. This trial also showed statistical significance in breathing without assistance on day 28 with 66% versus 55% and more ventilator-free days, 12 days versus 10 days, compared to the traditional tidal volume group, which was your 12 ml per kg. So the incidence of barotrauma did remain the same between the two groups, and that was consistent with previous studies prior to the ARDS trial. And the absolute risk reduction of 9% meant that it correlated to the number needed to treat of 11 patients in order just to prevent one death. So guidelines now recommend that tidal volume should target anywhere from 4 to 8 ml per kg of predicted body weight and go down as low to 4, pending if plateau pressure targets are not achieved. So your plateau pressure should not exceed 30, given that the chest wall effects are normal. So optimizing PEEP is one of the first considerations in patients with refractory hypoxemia due to diffuse parenchymal lung disease, like ARDS. So PEEP is your holding pressure in the lungs during exhalation phase of mechanically started breath. It primarily increases the functional residual capacity of the lungs and increasing surface alveoli. Initial PEEP is typically 5 and it's titrated up with a goal arterial oxygenation with the upper limit being 20. So the strategy is it can decrease and prevent oxygen toxicity because it allows for lower oxygen requirements. In your ARDS patients, higher PEEP may improve alveolar recruitment, reduce lung strain and stress, and also prevent atelectic trauma. However, it does have its potential risks, such as injury to the end inspiratory alveolar overdistension. It can cause increased intrapulmonary shunt, as well as increased dead space, and ultimately sometimes leading to hemodynamic instability. So the American Thoracic Society of 2017 guidelines suggest that patients with moderate to severe ARDS receive higher rather than lower levels of PEEP. And this evidence to support this recommendation comes from 2 separate meta-analyses that looked at 8 randomized controlled trials and 3 randomized controlled trials. So the first one showed that higher versus lower PEEP strategy was evaluated in 8 randomized controlled trials. However, 2 of those trials did not use low tidal volumes. There was no difference in The mean difference in PEEP was 15 versus 9 in the higher and lower PEEP groups. And there was no significant difference in mortality between these two groups, and there was also no difference associated with increased barotrauma or new organ failure in the patients that received the higher PEEP. Later, Brielle and colleagues in 2010, they looked at 3 major studies, the alveolar study, LOV study, and EXPRESS study, and what they found is that patients with moderate to severe ARDS, which they classified as a P to F ratio of less than 200, who were randomized to the higher PEEP had significantly lower mortality. And then there was no significant difference, however, though, in patients that were classified with mild ARDS. So when thinking about ventilator settings for ARDS, and the SCCM 2021 COVID-19 guidelines actually recommend the same recommendations as your typical ARDS patient. So they recommend using your low tidal volume, which is your 4 to 8 ml per kg of predicted body weight, over higher, and then they also recommend using higher tidal volume, they also recommend using lower tidal volume over your higher tidal volume while keeping your plateau pressure less than 30, and they support the higher use of PEEP as well. All right, and this will get us into our second self-assessment question. So same process as before. Which body weight should be used to calculate tidal volume in ARDS patients? A, predicted body weight, B, actual body weight, C, adjusted body weight, or D, it does not matter which weight is used. So anybody for A? Very good. All right. B, C, D. Yes. All right, so it was A. All right, and now we'll get into drugs that I actually know a little bit more about, and we'll talk about neuromuscular blockade, which is your non-ventilator strategies. So, when thinking about neuromuscular blockade, there's actually multiple theories behind using neuromuscular blockade in ARDS. So it reduces patient ventilator dysynchrony, the work of breathing, and accumulation of the alveolar fluid, which when you're thinking about your typical ARDS patient, this can be extremely beneficial. They may also reduce the risk of barotrauma. And cisatracurium is the most commonly used continuous infusion for neuromuscular blockade in these patients. So it does have specific mechanisms itself, such as reducing oxygen consumption, improve ventilation perfusion relationships. It can prevent the pendulum effect, which is also known as the swinging of air. So when gases pass back and forth between the different regions of the lung, this effect occurs when the regions have different dynamics of the regional inflation and deflation. And then lastly, Nimbex itself is thought to have some direct anti-inflammatory properties. So prior to Acurasis in 2010, there was actually 2 smaller sub-studies that looked at neuromuscular blockade in ARDS, and they did show improvement in P to F ratios when the use of neuromuscular blockade was given. However, Acurasis in 2010 was one of the first trials that truly brought attention to using neuromuscular blocking agents in ARDS. So the purpose of this trial was to evaluate the clinical outcomes at 2 days of therapy with neuromuscular blocking agents in patients with early severe ARDS. It was a multi-center, double-blind, placebo-controlled trial that looked at cisatracurium 15 milligrams IV once, followed by a 37.5 milligram continuous infusion for 48 hours versus placebo. They included patients who were mechanically ventilated for acute hypoxemic respiratory failure with a P to F ratio of less than 150 on the ventilator and set to deliver a PEEP of at least 5. Their P to F ratio was 150, and they had to have at least a tidal volume of 6 to 8 ml per kg of predicted body weight, and they had to have the bilateral pulmonary infiltrates on chest x-ray. About 10 years later, the Roche trial was published in 2019, and they did their best to replicate Acurasis. So the similarities included the same neuromuscular blocking agent at the same dose and same duration. However, the key difference was in your placebo group, they used a lighter sedation targeted profile of a RASS of 0 to -2 to match consistent with the current practice recommendations. They evaluated early use of continuous neuromuscular blockade with cisatracurium, an improvement in mortality, and they used current light sedation protocols. This was the multi-center, unblinded, parallel group randomized controlled trial, and they included similar patient population to Acurasis, but they did look at hospital death from any cause at day 90. It is important to realize that in both of these trials, they did allow an open label bolus of 20 milligrams times once of cisatracurium if the patient's end inspiratory plateau pressure remained greater than 32 for 10 minutes and could not be fixed with deeper sedation or changes in tidal volume or PEEP. So in the Curasis trial, those treated with cisatracurium for at least 48 hours of the course of severe ARDS improved adjusted 90-day survival rate, increased the number of ventilator-free days, decreased days outside the ICU, and decreased the incidence of barotrauma. It did not significantly improve overall mortality at day 90, and it was actually just in the subset of patients that presented with a P to F ratio of less than 120. So among those patients, cisatracurium had a mortality of 30.8% versus 44.6% in those who did not receive neuromuscular blockade, which was statistically significant. These results ultimately led to neuromuscular use throughout the years. Rowe's trial, however, in 2019, this trial was stopped early due to futility, and at 90 days, in-hospital death was no different from using cisatracurium versus using placebo. So one thing to note is that the open label dose that I've said previously, the 20 milligrams times 1, was more frequently given in your placebo groups in both trials. So when comparing these two trials and these results, one saying yes, it has a mortality benefit, and one saying it does not, it is important to realize that when you're looking at ARDS treatment, over 10 years, our treatment recommendations have continued to grow. So proning came into play during that time, as well as the evaluation of higher PEEP. And as much as the Rose trial actually tried to match the patient population from a Curasis, they enrolled patients within 8 hours of ARDS compared to 16 hours like a Curasis. So that means that they could have included the modern phenotype of ARDS, which is called your rapidly improving ARDS, not meaning that those patients actually don't typically act like our true ARDS patients. And they also excluded patients that were already on IV continuous neuromuscular blockade, meaning that the sickest patients might have been excluded, and that could have altered the results between the two trials. All right, so in summary, the 2016 SCCM guidelines published that yes, we should use neuromuscular blockades and patients should probably benefit. However, this was prior to Rose being released. So then the Journal of Intensive Care Medicine in 2020 came up with the update saying that the benefit of neuromuscular blockade likely involves the avoidance of vent dysynchrony and improvement in lung compliance, but the trial showing reduction in mortality is still out to figure out, and mortality benefit remains unknown. The COVID-19 guidelines, they have weak recommendations using neuromuscular blockade. They do suggest that using intermittent boluses over continuous infusion to obviously limit the amount of neuromuscular blockade use because it does come with side effects. However, they do recommend that if you do have consistent ongoing need for deep sedation and vent dysynchrony, you can use a continuous infusion neuromuscular blockade. And now I will pass it off to Kylie.
So now we're going to talk about prone positioning, which is another non-ventilatory strategy in the treatment of ARDS. So prone positioning alters the mechanics and physiology of gas exchange, which results in consistently improved oxygenation. Some potential physiological benefits of proning include a more homogeneous pleural pressure, better perfusion and aeration of the dorsal lung, which therefore decreases intrapulmonary shunting. My bad, guys. I'll get the hang of this. Sorry. Eliminating compression of the lungs by the heart, improving ventilation perfusion matching and lung recruitment, decreasing ventilator-induced lung injury, decreasing release of pro-inflammatory cytokines, and it also improves PaO2 while decreasing PaCO2 and pPlat by recruitment, which therefore decreases pulmonary circulation and improving RV dysfunction. So Guerin and colleagues conducted a trial entitled Prone Positioning in Severe ARDS, also known as the PROSEVA trial. The purpose of this study was to explore whether early application of prone positioning would improve survival among patients with ARDS. This was a multi-center, randomized, prospective controlled trial that included 466 patients. And patients were included if they had ARDS, and they defined that as a P to F ratio less than 150 with an FiO2 of at least 0.6, a PEEP of greater than 5, and a tidal volume of 6 mils per kilo of predicted body weight. And they also had to be mechanically intubated for ARDS for less than 36 hours. Patients were randomly assigned to either the prone group or the supine group. If patients were assigned to the prone group, they were proned within 1 hour of randomization and then remained in the prone position for at least 16 consecutive hours. Patients in the supine group remained in the semi-recumbent position. Mechanical ventilation was delivered in a volume control mode with constant inspiratory flow and a targeted tidal volume of 6 mils per kilo. PEEP was selected based on a PEEP to FiO2 table that the trial utilized. The primary endpoint was death from any cause within 28 days after intubation. Some secondary outcomes also looked at death from any cause at 90 days, the rate of successful extubation, which was defined as non-reintubation or no use of non-invasive ventilation within 48 hours post-extubation, time to successful extubation, length of ICU stay, and ventilator-free days. Baseline characteristics were well matched between the two groups, except for the SOFA score and vasopressor use, which was higher in the supine group, versus neuromuscular blockade use, which was higher in the prone group. The average number of prone sessions per patient was 4, with the mean duration of proning of around 17 hours. Patients were ventilated in the prone group for approximately 73% of the time that they spent in the ICU from first to last prone. The P to F ratio in the supine position for the prone group was significantly higher at days 3 and 5, whereas the PEEP and FiO2 were significantly lower. The primary endpoint of death at 28 days was significantly lower in the prone group than in the supine group, and this continued on to the 90-day mark. And of note, they also assessed this despite the difference in SOFA score, vasopressor use, and neuromuscular blockade, and this finding still held true, that there was a decrease in mortality in the prone group than in the supine group. The rate of successful extubation and the number of ventilator-free days at days 28 and 90 were also significantly higher in the prone group, but they did not find a difference between the groups in length of ICU stay. So some important aspects to consider before initiating prone positioning is early application of proning when severe hypoxemia persists despite initial stabilization, proning for ideally greater than 12 hours a day, adhering to a lung protective strategy, which is a tidal volume of 6 mils per kilo of predicted body weight, and a P-plat of less than 30, utilizing experienced and specifically trained staff that are familiar with proning, optimizing PEEP for alveolar recruitment, and discontinuing proning when oxygenation is improved, and that's defined as a P to F ratio greater than 150, a PEEP less than 10, and an FiO2 less than 0.6 for at least 4 hours in the supine position. So once the patient's flipped from prone to supine, they've got to maintain those for 4 hours. Some potential complications of proning include ET tube obstruction or even dislodgement, pressure ulcer formation to the face, the chest, or the knees, loss of central access, and also the increased use of sedation. Some contraindications to proning include spinal instability, unmonitored elevated ICP, severe hemodynamic instability, an open abdomen, unstable fractures, and then late-term pregnancy. So another non-ventilatory strategy utilized in ARDS is the use of inhaled vasodilators, and specifically today I'll be talking about inhaled epoprostenol and nitric oxide. So there are 3 main physiological advantages of inhaled pulmonary vasodilators. Those include reduced pulmonary vascular resistance, improved ventilation perfusion matching, and reduced blood flow through a right to left shunt, all of which lead to short-term improvement in oxygenation. So nitric oxide is a gas which functions as a cell signaling molecule. Within the lungs, nitric oxide stimulates increases in cellular cyclic GMP in vascular smooth muscle, which leads to vasodilation, which often results in better oxygenation and lower pulmonary arterial pressures. It has been shown to shunt blood away from non-ventilated areas of the lung to more ventilated areas of the lung. It may also suppress platelet aggregation. So dosing for nitric oxide typically starts and caps at 20 parts per million for intubated patients. It's important to note that with prolonged use of nitric oxide, the effect starts to wear off after days. It's administered through an endotracheal tube, nasal prongs, or high-flow nasal cannula. Clinically significant improvement in oxygenation should be seen within an hour of initiating nitric oxide. Adverse effects include increased risk of developing renal dysfunction and systemic methemoglobinemia, but of note that's typically with doses greater than 80 parts per million, which we usually don't see. So methemoglobinemia is pretty rare. Epoprostenol is an inhaled prostacyclin, which is a naturally occurring prostanoid that's endogenously produced as a metabolite of arachidonic acid in your vascular endothelium. So epoprostenol is going to interact with the prostaglandin 1 receptor, which leads to increased levels of intracellular cyclic adenosine monophosphate, or CAMP, which subsequently leads to relaxation of vascular smooth muscle. It also has anti-thrombotic, anti-fibrotic, and anti-inflammatory effects. It has a half-life of around 2 to 5 minutes, so it's always important when we're running inhaled epoprostenol to have a backup syringe handy at the bedside. After discontinuation, oxygenation will return to baseline in about 30 minutes. Dosing of inhaled epoprostenol in ARDS is typically between 10 to 15 nanograms per kilogram per minute, or in micrograms per kilogram per minute, that's 0.01 to 0.05 of ideal body weight. It is traditionally delivered via a nebulizer into a ventilator circuit of an intubated patient. However, a high-flow nasal cannula can be utilized. It's also most effective when using a mesh vibrating nebulizer such as the Aerogen Solo. Of note, it's significantly less expensive than nitric oxide. Potential mechanisms of benefit of inhaled vasodilators in ARDS include improvement in oxygenation, reduction of pulmonary hypertension, and acute RV dysfunction, and it can also be used as a bridge to another therapy such as ECMO. So Buckley and colleagues compared fixed-dose inhaled epoprostenol and inhaled nitric oxide for ARDS patients in the ICU. This was a retrospective cohort study that took place from January 2014 to October of 2018 in a large academic medical center. The purpose of this study was to compare the clinical and economic impacts between inhaled nitric oxide and fixed-dose inhaled EPO in adult ARDS patients. 239 patients met the inclusion criteria, which consisted of an age greater than 18, continuous administration of inhaled epoprostenol or nitric oxide for at least 1 hour in mechanically ventilated patients in the ICU, and they had to have moderate to severe ARDS, which was defined as a P to F ratio less than 150. 139 patients received inhaled epoprostenol at a fixed rate of 8 mils per hour, which calculated based on the concentration they used was around 2.7 mics per minute of epoprostenol. And the attending was allowed to wean the epoprostenol down to around 1.3 mics per minute, but they were not allowed to go above 2.7. Epoprostenol was infused via an Aerogen Solo nebulizer system. 100 patients received nitric oxide via the Inomax DSIR Plus specialized delivery system. Weaning of nitric occurred once the FiO2 was less than 60, with dose reductions of around 5 parts per million every hour as it was tolerated. The primary endpoint of this study was to compare the change in the P to F ratio at 4 hours from baseline. Secondary endpoints included the frequency of responders, and a responder was defined as an increase in the P to F ratio by at least 10% 4 hours from baseline after therapy was started. They also looked at total drug costs and mechanical ventilation duration. The mean administration duration of inhaled epoprostenol was around 109 hours compared to 66 hours with nitric oxide. There was no difference found between the two groups in the mean change in the P to F ratio at 4 hours from baseline. The responder rate at 4 hours was also not different between the two groups. Response rates were similar at all evaluation periods up to 72 hours. And both groups showed an increase in the mean P to F ratio at 4 hours from baseline and maintained this effect up to 72 hours, which you can see in the graph with it sloping up. The inhaled epoprostenol group was associated with more mechanical ventilator-free days compared to the nitric oxide group. They also looked at costs, and drug expenditures with inhaled epoprostenol were significantly or substantially lower than the cost of nitric oxide. So in summary, inhaled pulmonary vasodilators have been shown to improve oxygenation and reduce pulmonary pressures. However, they have not been shown to improve mortality in ARDS patients. They should not routinely be used in ARDS. However, they are often used to stabilize ARDS patients who are failing to respond to other treatments, often as a bridge to another therapy. The best candidates for inhaled pulmonary vasodilators might be patients with at least 2 of the following: hypoxemia that's refractory to conventional therapy, right to left intracardiac shunting through a PFO, or right ventricular dysfunction, which is often seen in acute or chronic pulmonary hypertension. The COVID-19 treatment summary guidelines have a weak recommendation against the use of nitric oxide in mechanically ventilated adults with COVID-19 ARDS. They also have a weak recommendation for a trial of inhaled epoprostenol as a rescue therapy in mechanically ventilated adults with COVID-19 severe ARDS and hypoxemia despite optimizing ventilation and other rescue strategies. If no rapid improvement is seen, though, while administering the inhaled epoprostenol, it's recommended to taper off. So this leads us to our third and final question. Which of the following statements is true regarding the use of inhaled vasodilators in ARDS? Is it A, nitric oxide and inhaled epoprostenol have been shown to improve mortality in patients with ARDS? B, inhaled vasodilators should be recommended first line in patients with ARDS. C, inhaled vasodilators have not been shown to improve mortality in patients with ARDS. Or D, using nitric oxide and inhaled EPO together improves patient outcomes with ARDS. So I don't have anyone for A, B, C, D. Okay, so it is C. They've not been shown to improve mortality in patients with ARDS, but they are often utilized for refractory hypoxemia as a bridge to another therapy, such as ECMO. Thank you.
Sorry, guys. We'll wrap it up shortly. I'm sorry, I know it's a longer presentation. All right, so the last topic that we'll get into is steroids, and I know this is one of the most controversial topics in ARDS. And I will briefly do a quick summary, but this presentation, or steroids could be probably an hour presentation alone for ARDS. So the role of corticosteroids in the management of ARDS has continued to be a controversial topic since the 1980s and continues to incite debate. So when thinking about this, steroids should be considered, because when you think about the pathological complex changes in the lungs that manifest of persistent ARDS, it is characterized by ongoing inflammation and parenchymal cell proliferation and disordered disposition of collagen, and all which may be responsive to corticosteroid therapy. All right, so I know there is a lot on this slide, but we will touch briefly on the methylprednisolone trials that stand out in ARDS. So Maduri conducted 2 of these trials, one in 1998 and almost 10 years later in 2007, and ARDSnet published one in 2006. These trials all had similar objective data, and they were looking at methylprednisolone of efficacy, safety, and mortality benefit in ARDS patients. All had similar dosing strategies, as you can see in the top box, and they used a weight-based dosing of methylprednisolone. When thinking about your average 80 kilogram patient, this equals to roughly 160 milligrams of methylprednisolone as pulse dosing in the first 2 trials and 80 milligrams as a continuous infusion in the last trial. The patient population was similar among the 3 trials, roughly a 50-year-old male that had an average Apache score anywhere from 57 to 86 and a P/F ratio of 122 to 150. The first trial showed that prolonged administration of methylprednisolone in patients with unresolving ARDS was associated with improvement in lung injury score as well as reduced mortality. However, they did find delayed administration of methylprednisolone in patients that did not improve with the placebo was associated with a 50% failure rate, which was statistically significant for failure to improve with a p-value of 0.04, indicating that methylpred should not be used before the fibroproliferation phase advances to end-stage acellular fibrosis. The ARDS in 2006 did not support the use of methylpred for persistent ARDS. There was no significant difference in 60-day hospital mortality, and the methylprednisolone group had significantly more ventilator-free days than the placebo group during the first 28 days. Additionally, they did find that treatment with methylprednisolone was associated with significantly increased mortality among patients who had ARDS for at least 13 days or more. Maduri's second trial in 2007 showed that methylpred was associated with significant improvement of pulmonary and extrapulmonary organ dysfunction, as well as reduction in mechanical ventilation and ICU length of stay. So in summary, these trials had mixed results across the board, but they did find out that in ARDS regarding mortality, it should not be used in patients that have prolonged ARDS into their course for greater than 13 days, as it did increase the mortality in those patients. So DEXA ARDS, this was just published prior to COVID-19 and 13 years after the last methylpred trial. It was released, and the objective of the trial was to determine if adjunct treatment of persistent ARDS with dexamethasone changes the pulmonary and systemic inflammatory response and thereby reduces morbidity, leading to decrease in duration of mechanical ventilation and a decrease in mortality. This was a prospective, multi-center, randomized controlled trial of intubated adult patients with acute onset of ARDS with a P/F ratio of less than 200 on a PEEP of 5 or more. Patients were randomized to receive IV dexamethasone 20 milligrams on days 1 through 5, followed by 10 milligrams on days 6 through 7 versus placebo. Treatment continued for 10 days, or if the patient was extubated, whichever one came first. The primary endpoint was the number of ventilator-free days, which was defined as alive and free from mechanical ventilation at day 28 after intubation. It is important to note, because clinicians were aware of the group assignments, a patient in the control group that had non-resolving ARDS could receive and that had an indication other than ARDS for corticosteroid therapy could receive corticosteroids. So the DEXA ARDS results showed that patients in the dexamethasone group had a greater mean number of ventilator-free days than did the patients in the control group. Mean 12 days in the dexamethasone group versus 7 days in your placebo group. It also showed that 60 days after randomization, 21% of patients allocated to the dexamethasone group versus 36% in the control group had died, meaning that 1 death in the 60-day period was avoided by every 7 patients treated with dexamethasone. ICU mortality and actual duration of mechanical ventilation in ICU for survivors was also statistically significant, favoring dexamethasone. However, within the 28-day period after randomization, 19 patients in the dexamethasone group versus only 7 in your control group ended up having developed extubation failure, meaning that they had to be re-intubated or reconnected to mechanical ventilation if they had a tracheostomy. So the recovery trial was published 6 months after the COVID-19 pandemic began, and the results kind of took the medical field by surprise. The objective of the study was to report the results of dexamethasone use in patients with COVID-19, and this was an investigator-initiated, individually randomized, controlled, open-label adaptive platform trial. The patient population consisted of hospitalized patients with clinically suspected or laboratory confirmed COVID-19, and they were stratified by respiratory requirements. The average age of your study participant was 66 years old, 36% were female, and 24% had diabetes, 27% had heart disease, and 21% had a chronic lung condition. At time of randomization, 16% required mechanical ventilation and or ECMO, 60% were receiving oxygen either with or without non-invasive mechanical ventilation, and 24% were neither of those two groups. Only 82% of patients in the trial, though, had a laboratory confirmed diagnosis of COVID-19. Patients were randomized then to a 2-to-1 ratio of dexamethasone 6 milligrams IV or oral for 10 days or until discharge, whichever came first, versus your usual care. The primary endpoint was all-cause mortality within the 28 days of randomization, with secondary endpoints being time to discharge from hospital. This trial did show statistically significant fewer patients allocated to the dexamethasone group died within 28 days after randomization compared to usual care. However, the results did vary according to the level of respiratory support. The incidence of death was lower in the dexamethasone group compared to usual care among patients receiving invasive mechanical ventilation or those receiving oxygen with or without non-invasive mechanical ventilation, but not among patients who were receiving no respiratory support at the time of randomization. So I know I quickly went over the steroid trials, but the debate is still out regarding the steroid and what dose and who should get the steroid. So does the type of steroid matter? Steroids can be broken up by the type of receptors they work on, such as your glucocorticoid receptors and your mineralocorticoid receptors. Glucocorticoid receptors have a positive anti-inflammatory effect, but end up causing more hyperglycemia. Mineralocorticoid stimulation will cause sodium retention, which can promote volume overload and volume retention, which is particularly undesirable in your ARDS patients because dry lungs equal happy lungs. There is also weak evidence that the mineralocorticoid stimulation with aldosterone could further exacerbate ARDS. So when thinking about your typical steroids that we see in our ICU patients, there is dexamethasone, which has no mineralocorticoid activity, to hydrocortisone, which has mostly mineralocorticoid activity. So when picking the type of steroid, it's important to consider the pathophysiology for the underlying cause of ARDS, as well as be cognizant of the side effects that the steroid might cause. Other advantages to dexamethasone alone, besides having no mineralocorticoid activity, it does have a biological longer half-life, so it can be stopped in patients that when they're extubated, it actually auto-taper off the patient compared to just a blunt stopping of some of the other steroids. So in summary, steroids in ARDS still remains unknown, with mixed data spread across the board. When thinking about using steroids in ARDS, it is important to think about your patient and what the cause of and where they are in their ARDS course. So if the patient is greater than or equal to 2 weeks into their ARDS course, steroids should not be an option, knowing that it does increase mortality based on 2 of the methylpred trials. It is important to also consider the cause of ARDS and the underlying pathophys behind that disease state. So if it's COVID-19, we know that patients requiring oxygen therapy, either invasive or non-invasive oxygen delivery, there is benefit from dexamethasone and should be used. However, outside of COVID, it's important to think about your other pathophys causing it. Is it septic shock from pneumonia versus a transfusion-related reaction, which those courses tend to be treated very differently. Another thing to consider is other treatment options and making sure that those are maximized, as we do know proper vent settings in those trials, such as proning as well, do improve mortality. So in conclusion, ARDS remains a hot topic in the medical research, as so many trials contradict each other regarding treatment recommendations. What we do know when thinking about ARDS, it can be broken down into your ventilator versus non-ventilator treatment strategies. Ventilator, it's important to keep your tidal volume for that low protective lung protection of 4 to 8 ml per kg of predicted body weight, and possibly higher PEEP settings. However, that is still being looked at as we speak. When thinking about non-ventilator strategies, there's your neuromuscular blocking agents such as cisatracurium, your inhaled vasodilators such as inhaled nitric oxide or inhaled epoprostenol, the use of steroids, and the use of prone positioning. Most importantly, when thinking about your treatment options overall, you must consider the patient and the underlying pathophys behind ARDS itself. So we would like to thank you for having us here today, and we will take any questions at this time.